This is using research and data to create more fair neighborhoods. And our moderator is Dr. Amazia Coleman, a medical officer and physician in the Allergy, Asthma, and Airway Biology branch within the Division of Allergy Immunology and Transplantation at the National Institute of Allergy and Infectious Diseases. Say that 3 times fast. Dr. Coleman is currently leading studies in the Childhood Asthma in Urban Settings Consortium, the Atopic Dermatitis Research Network, and the Consortium of Eosinophilic Gastrointestinal Disease Researchers. She additionally leads a small business clinical trial focused on innovative treatments for food allergies. Dr. Coleman has expertise in health equity leadership and improving representation in clinical research studies. Over to you, Dr. Coleman.
Thank you. Thank you guys so much. I'll take a cue from Karen and have our guests introduce themselves. But just to start, I'll just say that as a researcher, I feel like all of the things that we've been talking about and discussing today are based in data. Data is really the building blocks for how we can scale to having health policies that are going to impact all of the communities that are experiencing food allergy. So I feel very passionate about data and making sure it's equitable. So I'll go ahead and have my panelists introduce themselves, and then we'll start a discussion. So Chris, go ahead and start.
Hi, everybody. My name is Chris Warren. I'm really grateful to be here with you all. My background's in epidemiology, and I've actually been doing food allergy research for almost exactly as long as FAIR's been an organization, and primarily around just trying to quantify the population level burden and mitigate it, along with the disparities we are all learning about.
Hi, my name is Justina Santi. I am a licensed marriage and family therapist, and I am the Senior Director of Navigation and Partnerships with the Southward Promise neighborhood in Newark, which is the first FAIR neighborhood.
Hi, I'm Ferris. With a name like Ferris, I don't think I need anything more. Kind of like Madonna, maybe. So I'm the father of 2 sons with food allergies. Gabe is 24. He's allergic to tree nuts. His younger brother Theo is 21. He's allergic to peanuts, tree nuts, and some seafood. We haven't quite figured out which ones exactly, raw versus cooked. I'm also the chief medical officer at DBV Technology. So people have called us the Peanut Patch Company, which I like to think we're more than just a peanut patch. We're a platform, so we can put just about anything you can think of on our product. So we're not approved yet. We're working on that. So I kind of wear 2 hats, my dad hat and my CMO hat.
I am a food allergy mom. I have 2 daughters who suffer from food allergies. Age is 7, who is allergic to shellfish. Age 4, who is allergic to peanut, tree nut, wheat, fish, shellfish, sesame, and an FPI is allergy to turkey. I am also a volunteer for Fair Neighborhood Chicago, and I am the founder of Don't Feed My Kiddo, which is an organization I founded still in its infancy to create awareness and increase education for food allergies. I'm also a nurse practitioner by profession.
Thank you all for sharing your stories briefly with us. I'll start with the parents on the panel who are also professionals as well in this space. And Aisha, I'll start with you and ask you to tell us a little bit more about your experience personally as a parent managing food allergies and how that has intersected with your professional experience as well.
So as a parent managing multiple food allergies, it has intersected with my personal experience in that trying to keep both of the girls safe and avoid reactions. Unfortunately, we've had 5 anaphylactic reactions in the 4 years of my one daughter's life. So given that, I've been working with her healthcare team to explore options of what we can do to decrease the severity of her reactions if exposed. As it relates to how that bridges to being a healthcare professional myself, we've been looking at clinical trials. And I know from my previous experience working in clinical trials in breast cancer that there are benefits to clinical trials, such as having access to medicines you might not otherwise be able to get, learning more about the study population, and then also contributing to research that might be able to help someone else later down the line.
Thank you for sharing that. Ferris, tell us more about your experience having children with food allergies and how that has influenced your approach to leading research when it comes to food allergies.
Yeah, for me, it's really interesting. So at times it's almost a blessing and a curse. So I've been doing this for about 20 years. So on the one hand, I feel like I'm pretty experienced in this and have a good grasp on drug development. But I can tell you, because of the indication, every setback that we've had as a company, just stabs at my heart, because I know what it means to patients, and I know that our product can help patients, and not just our product, but just to expand the whole landscape of what patients and practitioners need, which is more options, right? So honestly, there are times where I'm just like ecstatic to be here. And then other times it's just like, oh my God, this is killing me. But on a more concrete level, so what I try to do in my role as the head of clinical development, two things really very concrete. In our protocols, I challenge our team. Can we make these studies as patient friendly as possible? Do we really need that extra blood draw? Do we really need that extra visit? What are we going to do at that visit? Do we really need to ask our caregivers and parents for that extra data set? So we really do try to make our studies as patient-friendly as possible. We swim in pretty narrow lanes, though, as far as regulatory authorities and what we need to get done. So a lot of what you see in our protocols, you might think, why the heck are they asking us to do that? Well, it's not because we're mean or vicious. It's just we have to get that done. But the other part that I really love about what I do, and it's not mutually exclusive for my dad hat versus my CMO hat, is that at this company, they've really strived to generate long data sets. So 3 years, 4 years, 5 years, which is really unusual. But what that translates into is that we arguably have the largest pediatric peanut allergy data set in the world. And what I can do with that, I as in my company, is to leverage that into something that is really, for me, kind of a personal dream. If we can take that data set and one day combine it with everything that we have in terms of our banked samples and maybe go after replacing the food challenge. So that helps not only DBV, but imagine how that changes the landscape for everybody out there. So back to your question, there's a lot of what I do in my job where I'm thinking as a dad and as a father and as someone who's lived it, not before the job, but as part of the job. So the beauty of it, it's not mutually exclusive. They're both running in the same track. Unfortunately, at this particular company, there is a dedication to the science, and Hugh Sampson is one of our leaders here, and you all know the name. And part of the reason I'm here is because Hugh Sampson was at this company and is at this company. So for me, it's great. But to be honest, there are times where it just kills me because it's like, come on, let's go, people. We need to get this approved.
I definitely understand the sentiments. I appreciate that both of you, both appreciate the benefits to clinical research, clinical trials. We've talked about this earlier today that, you know, some people in our community just don't really have the trust, in gathering the data or doing the research, or there is, a myth that exists, or, we have a history of why this could be. And so the data, may be biased because of, you know, things like structural, injustices, racism. And so how do we think about, exploring the role of inclusive data in trying to improve health inequities that we see in food allergy? So I'll, start with you, Justine, and thinking about, in your work at the Southward Promise neighborhood, how do you use the data to address health inequities in food allergy?
I'll start by how we actually collect the data. So in the work that we've done, specifically with BRIC, with our Promise Neighborhood, was really conducting a needs assessment, with our community. So not assuming largely what's happening just by looking like, oh, okay, we know this is happening, but really going to the community and assessing what are the needs, and then hosting a slew of focus groups. So we not only manage schools, but really getting down to the table with parents, schools, community leaders, and having a diverse group of people at the table to talk about what the needs are. So we're collecting the data from a diverse group of people to understand what the community's needs are. So that's the first way we're collecting the data and how we're utilizing it to then inform what resources, what programming then we are investing in or bringing other organizations to the table to then have working in the community. So that's really where we're starting from, using the data that we broadly collect, getting down to the table, bringing parents and diverse group members, stakeholders, to talk deeply about it, and then channel it into our resources and services that we're then providing to the community.
Thank you for that. Can you tell us a little bit more about how the information that you got from your community needs assessment kind of help you expand to working and partnering with FAIR? Can you tell us a little bit more about that?
So the story of FAIR. So in 2020, in 2018, we won our Promise Neighborhood. In 2020, obviously midst of pandemic, I manage our Promise Neighborhood managed 30 semi-partners. I want to say maybe late fall, I get a call from one of our directors, board directors, and said, "Hey, we have this new partner, that I want you to meet with." I said, "I'm barely scraping to get the partnerships to do the programming that we need to do in this virtual space, because a lot of things had to transition with a lot of shutdown." Fair. And I was like, "What do they do?" "Food allergy." No joke. Marie and Anita showed up, and I'm like, I know that's important. It has not shown up in my data. So when you talk about data, we're talking about a community that we don't have affordable housing. I can't get food access. Okay. Our community is food apartheid, not food, insecurity. It is designed. There are not grocery stores accessible to our community. So you're telling me food allergy. I'm like, well, I can barely get food on the table for this community. So I'm like, food allergy, that's a stretch. I don't know how we're gonna, it's very important, right? I have food allergies myself, but I have family. I know that's very important. I just don't know how we're gonna translate this, especially in this virtual world. We're in the midst of doing our community survey, which we have to run every other year. And so it was almost a perfect storm in the sense that we were in the midst of that. And I said, you know what? Let's throw some questions on this community survey. And if the data comes back and says that the community says that they have a need for this, then we can further talk. And so they gathered some questions, and I was like, we'll put it on a community survey. And the data came back, and I want to say 25%, 22 to 20 said that this was a problem. And I looked at them, I was like, okay. Well, the community says this is a problem, so we have to address it. Then I turned to them, I was like, well, when you go back to trust in our community, and I said a community that's been divided, our community, we're very much on purpose in that community because that community was drowned of their resources, literally was split apart by a highway that was put by design to split up the community. So we're not just going to throw another program that they've seen happen, come in for a year or two and then disappear on them. What are you going to do long term if you're going to be in this neighborhood? What is that going to look like? Because we're not going to add another partner to the table that cannot be here for the long term. And so we talked about what programming looks like. And so as we talked, I was like, okay, that sounds good. Let's start the work. And in 2020 we really started the work. And in that iteration, we were applying for a promised neighborhood. And because I was so passionate about the work that we were doing, I ensured that not only do we continue, but that we have funding from our promised neighborhood to continue to work with FAIR. So I said, hey, I gotta submit this grant in like 2 days. FAIR, you want to be a partner in Promise? So this is where it flipped from you came to be our partner to now you want to be a partner in Promise. Sign this MOU. If we then are able to extend this 5-year grant, we are able to then expand the work that we're going to be doing here for 5 years. And luckily we were awarded the grant, and that's how it flipped from being just FAIR becoming a partner on that side to being a partner in Promise and expanding the work that we were doing.
I have a question that's a little bit related for you, Aisha, and then I'll come to you, Chris. And just thinking about, the community needs assessment is how you were able to understand what the community needed as far as getting more data to advance our work. From your perspective, Aisha, as a parent of a child or children with food allergies, what was it that convinced you that clinical research was important? And was it a combination of your lived experience and your professional experience, or what was it that kind of sold you?
So initially it was my clinical experience. But then as a parent, seeing repeated reactions despite our best efforts to avoid really made me move toward going forward with the clinical trial for my daughter. Knowing that there's no cure for food allergies, right? So this is going to be our only hope.
Thank you for sharing that. And Chris, you've been very vital in us understanding some of the gaps in our knowledge when it comes to food allergy health disparities. And can you tell us a little bit more about the FORWARD study and how you've been working with FORWARD and helping us kind of better analyze the data that we have and understanding what data we need?
Sure. So yeah, just a little background. One of the very first projects I ever got involved with in the food allergy research was a big national study, like now about 13 years ago, that surveyed about 40,000 households in the U.S. and came up with this estimate of, about 8% of U.S. kids are likely to have a food allergy, with a substantial proportion of them experiencing, severe symptoms. And, in terms of like the power of data, that little soundbite of about 2 kids in every classroom, I think really made it real to a lot of, not just like families, but, a lot of policymakers as well. And so when we looked deeper into those data, we saw, okay, like all these other, inflammatory diseases, the burden of food allergy is not equitably distributed across these different, racial, ethnic, and socioeconomic groups. And it appeared that, from that data, it was clear that, Black Americans, low-income Americans were disproportionately affected. And so using those data and then kind of like going back and seeing those patterns in previous data when they weren't really well interrogated at the time, gave us enough evidence to convince the NIH that we need to look at like this in a lot more detail. And so we were able to convince NIAID to fund a cohort where we simultaneously enrolled a cohort of 400, Black children with food allergy and their parents, 400 white children with food allergy and their parents, and then just proposed to follow them very intensively, but just follow them observationally forward in time, doing surveys every couple months, looking at their electronic health records. They're coming into the clinic every year, convincing them to give us, stool samples to do microbiome analysis, things like that. And in the process, we were able to learn a lot more about like the natural history of food allergy. And in terms of specific outcomes, we've really, that was 7 years ago. We started recruiting, and as an epidemiologist, it's like your dream is to develop a really big, rich cohort that you're able to retain long term, because for the first couple of years, you don't have a lot because you're just really trying to desperately enroll your sample. But then as you keep having success, and if you're able to convince your participants, in this kind of long-term collaborative relationship, then the data really start piling up, and then you can really learn some stuff. And so over the last few years, we've started to really learn some stuff, and that runs the gamut from understanding, there are huge disparities in implementation of prevention guidelines. In 2017, we published it was recommended that we feed infants at high risk, peanut containing products starting around 6 months. We found in our cohort, there were huge disparities in terms of who, was introducing peanuts when, and so that was kind of the first really clear, data that this implementation, much sadly like the implementation of a lot of other national guidelines, needs a heck of a lot more, effort to do it equitably. We found, and Anita and I kind of did a survey a couple of years ago before this, but we have found, very disproportionate, awareness and access to emerging immunotherapies, which is really important, because, for a while there were really no treatments at all except for avoidance. And now there are a number of therapies, that have been FDA approved and more hopefully coming. There's already disparities in who's affected, and then we're disproportionately treating certain populations. Like, that's only going to further, exacerbate these disparities. And that's especially egregious when we also see in the forward study that, low income Black and Latino Americans with food allergy, they have more reactions. They're more likely to show up in the emergency department due to their disease. They have more trouble accessing, allergen-free foods, and they actually pay more out of pocket for the management, necessities for this condition. And then even though in our study we've shown they have more severe reactions and more frequent anaphylaxis, they're less likely to use epinephrine. And some of that is due to access. Like Amari mentioned, that those epinephrine autoinjectors are expensive. We need to do a lot more in terms of educating folks on how and when to use them. And along those lines, we've also shown disparities in like caregiver knowledge, which highlight need to, really be a lot more deliberate and effective in advancing kind of equitable patient and provider and caregiver educational initiatives as well. And I could go on and on and on about all the things we've learned about Forward, but maybe I'll stop.
This is very, very helpful. I love the work that you guys are doing with Forward, and you can expound a little bit more about, why it's so important to have inclusive data when we're talking about, thinking about prevention, thinking about treatment, thinking about how our research is impacting community. And so can you talk a little bit about how or what your perspective is with regard to inclusivity in collecting the data? Because I feel like Forward is, very forward.
Yeah. Yes.
Forward thinking when it comes to doing the research.
Sure. Well, so I sort of neglected to add that because we had success in actually recruiting and retaining our original 800 participants, we then convinced NIH to give us more funding to recruit a larger sample of Hispanic and Latino patients who come from the Caribbean and like Mexico and Central America as well, to kind of look at some specific hypotheses there. And then we recently got another supplement to expand our cohort further to look at South and East Asian folks in the US. So we're sort of like backing our way into more of a general population cohort, but the whole time we've been very interested in trying to understand some like just the root mechanisms of a lot of these, just very apparent disparities we see in food allergy. And I guess, to me, the case is made just so obvious. Like, how can you look at this? How can you do this research looking at the root causes of disparities in these diverse populations without systematically engaging the diverse populations? Part of the reason why it took so long for people to, like when I first started in food allergy research, like, cause I was doing, other, kind of working actually with community health workers in the context of another study looking at disparities. People are like, why are you working in food allergies? Like, that's just kind of like a condition of the worried well, these like suburban moms who don't have anything else to worry about. And at the time I was kind of like, I don't know, maybe that's true. But we're going to look at it. But if you took 2 seconds to look at, okay, there's huge disparities in atopic dermatitis. There's huge disparities in allergic, asthma. There's huge disparities in environmental allergies. Why would food allergy be this one little outlier that only affects this completely different subset? It doesn't make any sense. And so, but it wasn't until we really started to try to enroll representative populations where the disparities are so obvious you can't avoid them. But if we had continued to just enroll these cohorts of convenient samples at these major tertiary care institutions, you could easily just kind of pretend like the disparities aren't there because you don't have the hard data to make it so clear, So,
Yeah. In talking about centering equity, in our food allergy research, Ferris, can you talk a little bit about, in your role as Chief Medical Officer, what is the importance of equity in the work that you do at DBV?
Yeah, for us, it's important as we try to move our clinical trials forward. We know that the FDA is always in play, EMA is always in play. They have different degrees of what they will mandate or suggest in terms of diversity and inclusion. We know the FDA has a project they're trying to move forward. But that's really not what motivates us. So we really try our best to go and work with the patient advocacy groups to help us. We know that as the sponsor, we can go to specific sites that are in these areas, but that's not really enough. And we have tried to do that. And it really does take a community. We admit fully that we can't do it ourselves as a sponsor. We need everybody's help, right? So we've tried our best to reach out and diversify. Unofficially in our current trial, we think that we have as high a number of participants that fall into a minority category than we've ever had before. So we're encouraged by that. We haven't cut the data just yet. This is the VITESSE trial I'm talking about. But we realize that we can't do it ourselves. So we really need a lot of help. And for us, it's important to be able to understand our product to make sure that it works across a diverse racial background population, right? The last thing we want to do is to unleash a product into the public and we realize, it doesn't work for this group of patients. We don't think that's the case. And most products, that's not the case, but you want to be sure, right, before you do that. So in my role, we really try to do that. I work with Angela a lot to try to work with the advocacy groups. And even our investigators, we try to go to sites that we can. But again, there's a trust level too. So we have to rely on them to send the message that this is a reputable company. Hopefully that's a reputation out there. And again, my message is we can't do it alone as a sponsor, and we know that.
That's very critical, very vital. So I'm very glad to, hear that you feel this way in your role. Coming to you, Justine, how does this resonate with you with regard to centering equity and kind of going further in the work that you're doing in your role in partnerships in New Jersey?
I think it's definitely important building that trust of like hearing, going to the trusted source. The one thing that I feel like when FAIR came, I was like, well, we're central located, we're, the pillar in the South Ward right now, where we're galvanizing all these 30 semi partners. And so let me also connect you with the other players in the building that, you should be known for. So definitely getting them into our, health collaborative action network and being able to spread that, across, that really helped to amplify the work that they were doing, spreading the equity, alongside that. So it is sobering to see how much Marie has connected with other organizations across the South Ward and Newark in general to get the word out, to inform more people across the district, continuing to push. So work that we've done, like we said, using data. So one thing that we've been able to do is open a federally qualified healthcare center in partnership with St. James Health. So hoping to continue to push much needed resources. Maybe we can get an allergy. I don't know. We only have one in the South Ward at our local hospital, but maybe we can recruit another one for our health center. Making sure that there will be a pharmacy that will be embedded in our healthcare center. So ensuring that our community has access, right? Equity in that sense. And then newer news that we got is that we got appropriations from the state to open a grocery store. So ensuring that we have access to allergy friendly food in that grocery store. So a lot of work that we're doing is ensuring that one, a voice is at the table, spreading the work that we're doing across the partnerships and continuing to drive deep. We said NERC has a lot of great resources, but ensuring that everyone is educated. And so continue to expand it. Another piece that we're doing is like when you say spreading what fair neighborhoods could be, is because we sit in a promised neighborhood and we are connected to another 38 promised neighborhoods, it's submitting a proposal so that FAIR can present. So hopefully, send positive energy for us that we get selected, so that in December, if we're able to present, that is another area where we continue to amplify not only to promised neighborhoods, but also to full community schools, that they can take advantage of the different training and toolkits that FAIR has. So that's where we see the work going.
Thank you for sharing that. I've heard the common thread about, funding and how vital it is for doing the work that we're doing. And I want to ask a question of all of the panelists. In your, opinion, I'll start at the end of the table this time. What data do you feel is lacking in the space? I guess that's the question. What data do you feel is lacking in the space with regard to food allergy discovery?
As it relates to data, I don't know if there's anything specific outside of data regarding African American and Latinos being in trials. We're not well represented, which further leads to lack of knowledge about those patient populations, which further increases healthcare inequity. So just getting those folks enrolled and educated will open up avenues where we are able to know how those populations will or will not respond to these medicines that are being produced.
Yeah, from my point in drug development, I think there's just not a lot of data on new products. There just aren't a lot of new products. So, what patients want and what prescribers need are different treatments for patients. But then how do we get there? We can't get there without clinical trials, right? So it comes down to me, it may not be a data question, but it's an education question, and it's back to the premise of trust, right? If we can't enroll, we can't get products approved. And so, and again, from the sponsor standpoint, we're the weakest link in the chain. There's a little that I can do sitting on my desk in New Jersey. I rely on everybody else to help us get across the line. I have no delusions. We just have ideas that we think could work, but without everyone's help, it just sits on my desk, right? So I think it's data, but it's also in the context of how do we get other products available in the marketplace and in the landscape for prescribers.
For me, I would say echoing everything that they've already said, right? There's not enough representation in the data, but also once the data is collected, also giving it back to the community, so that they're able to amplify their voice and increase the need for funding in these specific areas, right? Sometimes we collect the data, we utilize for it, but the data belongs to the community. If you collect it from the community, turnkey it back to the community. Communicate has voice and power, and they're able to do wonders to move initiatives. So giving the data back and helping them to help us raise fund.
And for me, this sounds like a very basic piece of data, but we still really don't know it, which is just who actually has food allergies in the U.S. Because we know so many people are living their lives with food allergies. We know that burden is real, and we know a certain proportion really genuinely are at risk of like a life-threatening anaphylactic reaction. But at the same time, there are a lot of people who are probably living as if they have a food allergy, but if they just had access to good diagnostic confirmation, they could then be non-allergic anymore, and you're cured. And like, there's few diseases where you can just cure somebody with like a little poke on the arm. But food allergy is one of those diseases, but due to all the horrible systemic problems we've been discussing, we're just not at a point where we can even like know that basic fact.
Yeah. Thank you all for sharing. I'll take this time to open up, questions to the audience.
Yeah. Well, I think
yeah.
Okay.
Thank you all for a really robust discussion and so informative, and really admire all that all of you are doing. I was going to direct my question to Drs. Warren and Coleman on the forward cohort. Would you comment on the differences you saw in the different allergens that are involved, and then the potential severity that you see in different populations? And then, do you have data that looks at, for example, like non-IgE mediated allergies like FPIES or other things in other populations and other groups? I was just curious.
Let me start.
Sure.
Okay.
It's of having two experts.
Yeah.
The room.
So I can tell you that, the data from Forward have been very consistent with the data from our other large epidemiologic studies that show, that lower income African American folks in particular, and particularly those living in urban areas, are much more likely to be allergic to seafood like shellfish, and that we've shown that about half potentially of the racial disparity in shellfish allergy between black and white kids is likely or could be attributable to sensitization to like common household allergens, so like people who get allergic to cockroach or house dust mite due to living conditions that are very able to be mitigated. That's sensitizing them to a protein that then is also present in shellfish and leads to shellfish allergy. So just like that's, I think, a very important finding, that like it's not necessarily like always the food itself. It's sort of these other environmental exposures that are kind of priming the pump, if you will, for these allergies. And we need to look more upstream. And we also see that, when you like I sort of mentioned about the severity of reactions to the different triggers. Yeah, shellfish tends to be a severe one that is disproportionately, present in the Black community and in the lower income urban communities.
Ditto. I think you answered it. Thanks for that.
Yeah.
I have a question for Ferris. So I loved hearing you say that you're thinking from a parent perspective about like, what are we asking families to do during these clinical trials? Because we know there's a lot of barriers just to participating. And as a psychologist, I think about like distress that kids are going through with food challenges. But I'm also really curious to know, like, as you listen to the community and what their needs and wants are in products and in, the landscape of food allergy, how is that shaping like your ideas about like what's next and what DBV is doing, as you're developing new products?
Yeah. So as I mentioned, the beauty of my job, I'm like a kid in a candy store because we have a platform. So what comes next? We have phase 2 data in milk. And when we go to congresses, the first thing people ask me is, where are we with the peanut patch? When does that come in? The second question always is, when is milk coming? We know you did that study. So back to your question, I think it comes down to what makes the most sense for what the patients need. Is it going to be sesame? Is it going to be cashew? Is it going to be something else after that? But once if we can get our first product across the line and approved, then again, like I said, it's sky's the limit for me in terms of what I can do. And one of the great things about DBV is we have great scientists that help me do my job, like Hugh Sampson and the rest of our allergists, Todd Green and Diane Campbell. And we can go wherever the need is. I think in a large extent, I joke with the people who make the patches. Is it going to be like pizza slices with different allergens, or is it going to be sprinkles like a sundae? But that's the type of thing we're thinking about and talking about for the future.
Hello. So I actually came in late, so I didn't get any of your names, but I have a comment and a question. The two comments that were made about the importance of making sure that we have minoritized patients participating in clinical trials so that we can, know how they respond. My comment before I have a question is, I just want to ensure that everyone understands that when we say we want representation in clinical trials from diverse populations, we're not suggesting that the reason we need that is because race is biological, right? There's no such thing as a black kidney or an Asian brain, right? The reason why we want to see what their responses are is not biological response, but the psychosocial response, right? So if you recognize that, understanding the ways that certain populations navigate social milieu in their life, right? The level of stress, which we know most certainly impacts metabolism and all the things, right? So that becomes biological, right? Or, the way they metabolize food, given our food allergy conversation, or even genetics, right? So it's not necessarily a conversation about race. I just want to be very clear. So my follow-up question to that is, have you seen any future trends towards social behavioral research and the importance of having that arm of clinical trials, that they understand the framing for why, we want these diverse populations? And then my comment to the other panelists, again, like I said, I don't remember your name, but you mentioned the importance of giving data back to communities. Absolutely agreed. And we know that the IRB does not allow that, right? So I want to know if you've ever had conversations with institutions like IRBs, like funders who, where there's power struggles of like, okay, you are the researcher, you own the data, and there's no benefit to the research, right? Right now we're doing it for research sake. There's no direct benefit, and how we can expand research so that there is a direct benefit now, not later, for me, and I actually can access that data. So I didn't know if you knew about any kind of research models that actually do just that.
I can talk about that a little bit. We do have open data policies within the NIH that allow us to reciprocate study results back to the community. That data has to be presented in a certain way so that it doesn't, identify individual participants. But that's one of the things that we're working on currently within the allergy branch, is thinking about the research that we're doing and making sure that the results are getting back to, the communities that we serve. So there are ways that we can do that, ethically and, provide the information.
But they don't own the data, right? I guess I was talking about the data ownership that we're talking about. And the whole world, the idea of the NIH is trying to move towards this is brand new. I don't, I'm not from the NIH, you're required to make your data acceptable to the public. So the public's data. It's no longer yours or the institution's, as long as it can be data identified. Because some of the data I get is talking with people. Someone talks about a very specific situation that'd be identifiable. So that will still be available. Just in a different way that will make it less. But it's not everybody. It's only NIH studies, only recent studies. So that will then hopefully expand to bringing data back. But then the data is owned by the public and not by that person, or that, well, truly not the person. All the research I do is
about the investigator.
It's not you. It's not my institution, but no longer. If it's through NIH, which will then serve as what everyone else should be doing, and then that will trickle up. But it's new.
Needs the microphone.
Sorry. But you brought something else up that I think is really important. Well, multiple things that are important, but the socio-behavioral research, right? That's what I do, but a lot of is not always fundable. And it's very difficult to fund. So what FAIR is doing is paving an innovative path. And what you guys are all doing within your communities is doing just that too. Saying that this is how we're going to get the beautiful things that you guys are doing in clinical research into the communities in an equitable way. And then I want to ask another question based on what you said and what everyone else has said, which is how do we then bring people within clinical trials that are diverse? How do we have that conversation, and how do we begin?
Well, just to kind of bridge the gap between these two comments, I think your point about the IRB is extraordinarily well taken. I was actually just talking to Dr. Scurlock right before this panel about our commiserating with our challenges, trying to educate our IRBs about some of these misconceptions they have about the extent to which, like, equitably compensating participants is not coercive. It's actually, like, equitable, and like, when just because somebody can participate in your study, while also doing their remote work from home job, and another person has to actually take time out of their, like, hourly, job and, like, travel to do it, like, they should be compensated for that time. And that shouldn't be viewed as, like, disproportionate or coercive. It should be viewed as, like, just. And so I think a lot of I think that sometimes researchers kind of tend to kowtow to their IRBs, like, because they see them as like the ultimate arbiters of like good and bad, and they could like squash things in the future. But I also think, that's not their role. Like, their role is to protect human subjects, and it's incumbent on researchers to be assertive with the IRBs about why something actually is ultimately protecting human subjects, because it's also not protecting human subjects to enroll a trial where you can't draw any conclusions because you've enrolled a completely, biased sample. And that's actually wasting everybody's time and resources, so you're spending maybe a little more money at the beginning because you're actually paying people, and, compensating people for taking the Uber to the clinic, or compensating people for the childcare or whatever. But, at the end of the day, it's actually not just like the just thing to do. It's better for everybody. So I would, people talk to your IRBs, educate them.
I'll give Ferris the last word because I've gotten the time up.
Okay, so what I could add to that is, for what we do in clinical trials for food allergies, the biggest barrier, or one of them, is the food challenge itself, because the caregiver will have to take essentially a whole day off from work to be able to attend and do the food challenge for their child. So if we can get a biomarker or some composite biomarker that would just require a skin prick test or a blood test and some composite, that takes away one of the biggest barriers for clinical trials, because they're scary and they're frankly brutal. If you've been through one, you know how stressful it is for the parent, not to mention the patient. So to me, I think as we move the entire landscape forward, that has to be one of our top priorities. I know FAIR has an initiative, that will go a long way to removing one of, in my opinion, the biggest barriers we have.
That's so true. Thank you all for such a robust conversation. We'll obviously be here to answer other questions that anyone may have, but thank you.
Thank you.